Sarah, people is hearing and seeing us?
Yeah, I see you.
Okay. Sarah, people is hearing and seeing us?
Yes. Give them around 2 minutes to start, please.
Yeah, I see you.
Okay. Sarah, people is hearing and seeing us?
Yes. Give them around 2 minutes to start, please.
Yeah, I see you.
Hello all, good morning. Greetings from Santander, Spain. Thank you all for assisting to this thematic workshop entitled Health and Telemedicine Solutions Empowering Person-Centered Care. What's been going on? Promoted by the European Innovation Partnership EIP program. My name is Galo Peralta. I'm the Managing Director of a Biomedical Research Institute in the north of Spain, Santander. I'm also the coordinator of the Spanish platform ITEMAS, an innovation platform in medical and healthcare technologies promoted by the Instituto de Salud Carlos III. First of all, I would like to say that we are delighted to host this meeting as AHA reference site. ITEMAS and IDUAL are committed with the promotion of the innovation in healthcare. The topic of this morning is undoubtedly quite relevant, especially at this moment. I would like to introduce this workshop with a brief presentation, remembering how this is framed in the European Innovation Partnership Program. As you probably know, this workshop is part of the European project We4AHA. We4AHA has the vision to shape the future of active and healthy aging in Europe by contributing to the transformation and innovation in healthcare. Now, the vision of We4AHA, due to the COVID pandemic, more than ever, is an opportunity for promoting health. In this situation, We4AHA vision reaches outstanding relevance. All we know that COVID is causing an unprecedented stress of healthcare systems. Health systems and services are being reconfigured to maintain patient continuity, and telemedicine has provided and is providing a powerful enabling tool to maintain this patient continuity and management of patients during COVID. Today, in this workshop, we have the opportunity of hearing some experience that have been developed in Europe that explore ways to develop healthcare, understand and share the challenges and opinions. We have the obligation to take advantage of this COVID pandemic and considering this an opportunity for review and improve our models of care of patients based on e-health. We'll try to enjoy this morning. We encourage your active participation with our speakers. We have a first slide dedicated to review some of the experience in the telemedicine projects. We have as speakers here with us to Marisa Oliveira. She will talk about TiChron. Oscar Van Dijk, he's the leader of the Medicine project, and Sana Inkeri that will present the INTENCIVE project. Marisa Oliveira will be the first speaker. Marisa is graduated in educational science in the University of Coimbra, Portugal, since 2002. In 2005, she holds a postgraduate degree in educational psychology. She has also a certificate of professional competence as a trainee since 2003 and has worked as a trainee during 8 years. Also worked in the area of recognition, validation, and certification for competence for about three years. She is part of the team of Future Balance since 2013 as assistant project manager, and there she has having a critical role for the development of one amazing project that is TiChron. She will present her experience in TiChron. Thank you, Marisa. That's your time.
So I have to share my screen with you. Are you seeing? Yeah?
Yeah.
Okay. So I'm going to present the TiChron project. It's about the use of ICT as a tool to improve the comprehensive care of children with chronic diseases. So I'm going to start to explain what is TiChron. Then I will speak about a little of Interreg SUDOE and the beneficiaries, objectives, task groups, and finally the results. So what is TiChron? TiChron is a collaborative project whose aim is to develop and implement an action plan for responding to the specific health needs of children and young people with chronic diseases, involving all their social environment. The challenge for this project is the implementation of the monitoring system for the health, avoiding their admission to hospitals and the appearance of risk situations not detected by caregivers. So we developed ICT tools for support and guide them in the follow-up of their chronic conditions. What chronic conditions are we talking about here? Mainly asthma, diabetes, and obesity. What is Interreg SUDOE? The Interreg SUDOE program is part of the European Territorial Cooperation Objective, known as Interreg, which is financed by one of the European structural funds, the European Regional Development Fund. The current programming period covers from 2014 to 2020. It also supports the regional development in Southwestern Europe, financing transnational projects through the ERDF. Also promotes transnational cooperation to solve common problems in the covered territory, such as low investment in research and development, weak competitiveness of the small and medium-sized enterprises, and exposure to climate change and environmental risks. So the beneficiaries of the TiChron project are 6. The coordinator is the Cantabrian Health Service from Spain. Also from Spain, we have the Center for Information Technology and Communication. From Portugal, we have 2 institutions, Future Balloons and University of Minho. From France, we also have 2 institutions, the Institute for Space Medicine and Physiology and the Network for the Prevention and Management of Pediatric Obesity in the Midi-Pyrenees. What are the objectives of the TiChron project? Are to solve the problems identified in the monitoring, treatment, and empowerment of children with chronic diseases based on ICTs and involving sectors of society that regularly interact with them, like family or teachers. We want to offer children, families, and caregivers optimized tools for care and early intervention in case of changes in their health. We also want to develop within the educational spaces of a positive atmosphere where the health and well-being of children with chronic pathologies are systematically supported and promoted with the help of new technologies. Finally, we want the improvement of the results in the health status of chronic patients, minimizing the impact on the daily life of children and normalizing the clinical and vital process. We have task groups of the project. We have specific ones and we have the transversal. Now, at this moment, we are starting with the GT3 implementation and pilot. We have already developed some tools. They are not all finished. And the transversal task groups, I believe that these transversal task groups are for all the projects. So project management, project communication, project follow-up, and evaluation. So the results now. The results of the TiChron project are closely related to the application of new technologies in the SUDOE space. This is evident in the following products: the creation of a multidisciplinary network, technologists, healthcare staff, patient association, thanks to the collaboration that emerged in this project to improve health support tools. Another product, the exchange of good practices, and also the integration of telemedicine within health services, and also the integration of telecare or teleconsultation in schools as teacher support. Also the use of gamification and virtual reality to promote adherence to treatments. Finally, monitoring health through apps. Now I want to present you a video. We have a video presentation of the project made recently by the coordinators that I want to share with you. Let's see. Just, we have the TiChron project as a website, tichron.eu. In the website, we have also the news about the project and this TiChron. Let me start.
Sorry, Marisa, we are not hearing the video. Maybe if you could share the sound of your computer as yesterday.
Okay, I believe that you are not listening. right?
That is.
Okay, let me try to...
Stop sharing the screen and put it again. Select the option of sharing sound of your computer.
Let me just...
Thank you.
Okay, now I believe it's fine. Sorry.
Los franceses a la obesidad, los portugueses al asma y nosotros aquí en España, en Cantabria, a la diabetes. Aunque nosotros hemos querido también pilotar con los niños de asma y de obesidad.
Lo que buscamos es normalizar la presencia de enfermedades crónicas en los niños, normalizarlos desde el punto de vista no solamente de ellos, que normalicen esa situación y que lo asuman como una parte más de sí mismos, sino que todo su entorno lo asuma como algo normal. ¿Dónde está la diferencia?
El proyecto desarrolla 4 herramientas: el chatbot, el e-learning, el juego y la teleconsulta. Un juego que consiste en un dragoncito que es un poco la mascota que le va a hacer entender un poco lo que es la diferente enfermedad, porque pasa por estados de crisis, porque lo tienen que cuidar y lo tienen que mantener sano. Un chatbot que nos va a permitir el seguimiento del paciente, de los niños, en este caso a nivel remoto, es decir, que sin que intervenga nadie más, esta herramienta va a cuestionar o preguntar al niño o adolescente sobre su estado de salud y él va a responder, y estas respuestas nos van a dar un feedback para entender qué es lo que está pasando con su seguimiento.
Y el uso de una plataforma de aprendizaje online, pero con carácter interactivo, para que ellos pueda haber un feedback y tanto ellos como sus familias, los profesores, etcétera, puedan incrementar sus conocimientos en el ámbito de estas enfermedades crónicas.
Y por último, vamos a utilizar la teleconsulta que ya tenemos implantada en el sistema cántabro de salud, que hemos hecho alguna modificación y que va a permitir que de manera remota, no presencial, los sanitarios puedan contactar con el niño y con la familia para el seguimiento del paciente.
Lo que pretende es mejorar la calidad de vida de los niños con enfermedades crónicas. No podemos tolerar que hoy en día, en el mundo en el que vivimos, un niño con diabetes, por ejemplo, se plantee no ir a una excursión con el resto de compañeros de colegio porque tiene que caminar una determinada distancia. Eso no es aceptable. Ese niño puede hacerlo, igual que los demás, con una serie de precauciones. Que no se vea como que una enfermedad es un lastre para su vida, sino que gracias al uso de la tecnología, ese seguimiento y control de las enfermedades crónicas va a provocar que su situación vital en cada momento sea mucho más positiva y mejor.
Y no solo ponerlo en marcha con estas enfermedades, sino que nos gustaría intentar desarrollarlo para más enfermedades.
Okay, so a very nice video presentation of the project. I believe I have finished. I will give my time to the rest of the time for the others. Thank you for listening.
Thank you, Marisa. The project has nice results. Thank you for the presentation. Thank you for the work. I think that in TiChron, the best is still coming. So we have a lot of work to do, but,
yes,
and some amazing results, as you have commented. Now we have time for Oscar. Oscar Van Dijk is a serial entrepreneurship. Is a quite different profile than Marisa, and he is the founder of Medicine, a scale-up company in the Dutch e-health industry. Oscar studied at Delft University of Technology in Fontainebleau. After several years working at Philips International, he decided in 1919 he wanted to set up his own company. Medicine Man is now his 4th venture, but the first in the health sector. As director of Thornick Foundation, Oscar has been the advisor of the Dutch Secretary General of Health and initiated a national 20 million fast-track funding program for health companies. He's also a rock star health startup mentor. Until recently, he was an active member of the patient council in his local hospital. Thank you, Oscar, for your time, and we are expecting with passion your presentation, your time.
Gallo, thank you so much. I'll put on the presentation directly. Let me see. Share screen. Where is it? I think it's this one. Everyone can see this, Gallo?
Okay.
This is fine. Okay. Good morning, everyone. What I wanted to show you, and let me first start by checking how to. Oh, I cannot. I'm on the wrong one. Sorry. The screen sharing has stopped. Technical problems. Can you still hear me? Hello? Can you still hear me?
Yes, we can hear you.
Good. Apparently, it's the wrong one. Let me try again. Now, can you see the second screen?
Yes.
Okay, fine. So it works. So I was already introduced by Gallo. My name is Oscar van Dijk, founder of Medicine Man. And I have about 10 minutes to tell you just a little bit about the company and our products, but especially about our project, which now has become a product, EmmaCOPD. After telling you what our mission is in the platform, I want to talk about the Emma Care Circles, which is something which we developed over time, in which we realized that this is a very, very good model between a patient and professional healthcare givers. And then I will go into COPD, discuss a little bit about what is a lung attack and how important it is to recognize lung attacks for a COPD patient and to do something about it quickly. So what we do, we develop and market what we call medically effective and money-saving solutions based on a single telehealth platform. And we do this specifically for hospitals and general practitioners. And the vision we have is that all health professionals should work together. We don't see a hospital as a different thing than a general practitioner. Really, patients go from a GP to a hospital and back, especially chronically ill patients. So the way we set up our platform is about letting them work together around the patient and their family. So our company is 10 people. We're based in the Netherlands. I already told you we developed this software specifically for chronically ill patients. It's a modular platform. And as I just said, doctors, they can initiate what is called a care path around the patient. It can be a COPD patient, can be an asthma patient, but also diabetes or any illness people would have. Based on the platform, we have a number of modules. One is very successful, is HBPM, EmmaMHPM, home blood pressure measurement. So most GPs and GP now use this. It's really about remote measuring and putting your diagnosis remotely. The Emma Activity Coach is part of EmmaCOPD. It works together with a Fitbit smartwatch, not a tracker, but a smartwatch. So we were able to develop specific software for it. EmmaCOPD will tell a little bit more. PROM is probably those who are in healthcare know PROM is patient-reported outcome measurement. Any professional can use the platform to ask questions and set up questionnaires on the app of the patient. And they can do this also by scheduling or even using triggers. If something happens to the patient or there's a measurement wrong, they can set up a questionnaire automatically. EmmaMed is what we started 7 years ago, this medication reminding to improve adherence. And Emma Research is what we use for instance, for European projects where the people who set up the project don't want to first develop a platform, but start working on solution directly. And the newest thing we have since this year is to have the digital hospital. It's like a circle around the EHR of the hospital, and it does all the remote management, the remote measurement for patients outside of the hospitals. And as it's a platform that's agnostic to if it's a hospital or a GP, there's also a version for general practitioners. I told you I would tell you a little bit about our care circles. Well, I'm not a health professional. My father and my mother were doctors, but myself, I'm a technician. So when I started 7 years ago, Emma, a medicine man, I decided not to start from, say, the hospital or the health professional, but really from the patient. So the first 2 years, we only developed only for the patient. And I think in hindsight, that was a good concept, because now all our applications start from the patient. And the patient is the one who can do something with the signals they receive. So if a patient answers some questions, then we feed back, say, advices to the patient. This empowers the patient, and it also gives them the opportunity to quickly react. But of course, they don't always are able to do this correctly. So if a threshold is superseded, then we send a signal to chosen family members. Can be a text message with SMS, can be a mail. They also have an app and a dashboard. But really, family members are very committed and quick to respond, also during the weekend and the evening hours. This helps for medication, but even for people who don't move enough. But of course, there's also the professional health, and that's the third circle. And we work together with them more in a way where they do the goal setting and they coach the patient. But they can do this during regular office hours. So it's really about those circles, and all our applications work within Emma work this way. Well, this is just to show you what can be done. It's a lot about devices, but I'll continue into EmmaCOPD. Some data on COPD, just for those people who are not familiar with what chronic obstructive pulmonary disease is. It's really a big disease. 350 million people in the world have it, and they expect that if the trend continues, that in 15 years, COPD will be the leading cause of death worldwide. Most people, 90% of people with COPD, have COPD because they have been smoking. They have a smoking history. It can be with toxic particles, but that's a relatively small part of that population. And those people with COPD, they have small infections in their lungs. And that means that the air cells will break down over time. It's also not reversible. So people who suffer from COPD, their lung content, as we call it, will go down over time. And in the end, if you have no medication, then in 2 or 3 years, you would suffocate from that. But of course, with proper management and medications, patients can live 20 to 25 years longer than they would if they would not have any medication. So these patients also have what is called lung attacks, or as they also called exacerbations. They can be mild. This means that people feel that they really are a little bit suffocating. If they take their medication, it will probably go away. But if they leave this, then it gets worse, and they really have to go into to hospital. And those are what is called the severe attacks. And people stay roughly between 5 and 10 days in hospital before going back. And some of these patients have 4 to 6 attacks. So they are like a month a year in hospital. But of course, every attack, it causes more lung damage. So it's really important to make sure that those severe lung attacks are being prevented. As you can calculate, if people are in hospital for a month during a year, it can cost about 25,000 euros per patient just in hospital hours, which is 30 billion euros per year. This is something that was made by Jaap Trappenburg from UMC Utrecht, just to show you. On the horizontal axis, it's the number of days until a lung attack appears. And 0 is where people have a severe lung attack. And on the vertical axis, you can see how they function. And the baseline, which is the dotted line, is where they normally are. So if they get this attack, it goes up. This is the moment, as I said, when they go to hospital. This is where medication normally is given. And then after between 4 and 10 days, the attack goes away and they go home and they go back to hopefully the level they had before. But if you recognize the attack 3 days before and you give medication, as you can see, then the attack is not as severe, and people recover easily. And also they don't go to the hospital. And that's the idea about these kinds of applications, to really recognize and act quickly. So we developed two solutions which are like packed in one. One is what we call the lung attack recognition app. It's really a very sophisticated system with cloud-based, and there are like levels in there where if you have something is more severe, you have to act differently. But the basis is, if you have one question every day, and if you give like a positive answer, like I'm short of breath, then the app will advise you to up your medication. And it really, really helps. And the other one is really about long term, because people with COPD, they have their lungs should be in good physical condition. And because of their lungs, they don't do much more. So we developed this specific activity coach app. We use Fitbit smartwatches. So as you can see, the screens are really developed for chronically ill patients. It's totally different from what you normally see in trackers. And the ideas are also different. It's not about reaching your daily goal, but it's about staying in your zone. And if you get out of your zone, you get a warning. If you continue not to, say, move normally as you normally would, then a signal will go, that's the red, of course, will go to your one of your family members who can help you and get out of the couch. This one, I don't know how much time I have like 2 sheets, so Galo, be patient. Okay, good. Just to give you an idea how long this takes, as Galo already mentioned, this is my 4th venture, and my previous ventures were not in healthcare. And normally, if we develop a product, it's ready in a year, and then you start having revenues in the 2nd or 3rd year. This is totally different. In healthcare, really you have you have to develop, but then you have to validate, and then you have to find reimbursement. And this can take up to 10 years or so. Fortunately for us, it's smaller, but it's really not within 1 year. So we were fortunate to have some financing from a EU Interreg program, so we could develop together with patient and a hospital in co-creation our first product. And that worked really, really, really well. This was already two and a half years ago. But of course, we had not enough patients to show statistically significant that it really worked. So we started a new validation trial together with the Leiden University Medical Center. And this took 1.5 years to get there. And last year, at the end of last year, we got the results. And now in 2020, now finally we have the publication and the conferences, and we can start working on market introduction. So this really is, and this is quite fast actually, a 4 to 5 year program. So the results, and that's important of course, we started with co-creation with 10 patients. As I said, really got good results, but 10 could be a coincidence, of course. So we did another validation study, and this time with 35 patients, still not very much, but really you need to have specific patients because they need to have lung attacks before you start, because you have to see if there's a reduction. So that was one reason there were not so many patients during the period. But as you can see, it reduces the readmission rates to the hospital by 96%, and the number of days in hospital were reduced by 74. So this was for this category of patient 11 days per patient that they spent less in hospital. Patients were very happy, but of course, because they stayed out of hospital, but it was a very important point. This is the last one, and really it's too small font size to really see. But this is what Leiden now presented, and it's now out in the open. And we just started with new hospitals. And what is really interesting is we're now moving in 2 directions. One, we're setting up 2 parallel care paths for patients, those who are not self-reliant they get special monitoring from a monitoring center. And those, and this is what EmmaCOPD was meant to be, is those who are self-reliant and they can do without the monitoring. They really can do it themselves with EmmaCOPD. And then the second one, we also started a project with general physicians, because there are a lot of COPD patients, most of them actually, who are in GOLD 1 and 2, which is the first stages of COPD. And of course, they have never had a severe lung attack. That's why they're still with their GP. But now we're moving into prevention for that group as well. And the third one, and I hope that by the end of next year that will be in place, we will have connected the GPs and the hospitals. So people can actually move patients within the EMMA system between GP and hospital. I hope, Galo, this was not too long. I hope it was interesting. Thank you for your attention.
Thank you, Oscar. Congratulations for your work. This is a nice example of how complexes develop a platform for attention in telemedicine. You have a clinical validation that is also an enormous challenge for this kind of tools in medicine. So, and the results, as you have commented, are published and are there. So congratulations. Okay, so later on we'll have time, I'm thinking in the audience, for questions, for interactions with the speakers and with the participants. So, and the third speaker this morning will talk about the INTENCIVE project. Sana is the speaker. Sana Inkeri works as international coordinator at the Regional Council of South Estonia in Finland. She is currently leading an Interreg Europe funded project called INTENCIVE. IDIVAL participates in this project. The INTENCIVE means innovation and technology enhancing customer-oriented health services. And this project aims at improving quality and accessibility of health services for all citizens in aging society through user-oriented innovation driving health technology. Sana has a master's degree in economy and business administration. During several years, she has working with a variety of international projects of different fields like INTENCIVE. Thank you, Sana, for leading this amazing project. This is an amazing project for us, an amazing experience, and for your time today. And go ahead.
Thank you, Galo. Let me start by sharing my presentation. Okay, here we go. Yeah, yes, our project is called INTENCIVE, and as Galo mentioned, IDIVAL is working on the project as well. I will try to be short. I will talk about what is INTENCIVE, who we are, our objectives and activities. So we are a collaboration project between 5 regions. We're funded by the Interreg Europe program. And as some of you may know, the core of this program is about transferring good practices between different partner regions, and then implementing what we learn from each other. And this is done through the action plan, which each of us are doing. As Galo mentioned, we are working our situation is in the regions that we have decreasing population in the rural regions. We are working with the elderly people, so that is our main target group in this project. So far, we have worked for 1 year So we are still in kind of taking the first steps during our project. And then who we are, 6 partners from 5 European regions. So I represent the Regional Council of South Osterbothnia in Finland, and we are the lead partner. And then the Seinäjoki University of Applied Sciences is supporting us with the lead, and then they work as an expert on e-health more as well. Then we have from Hungary, Pan and Business Network Association, Ministry of Gozo from Malta, and then from France, Biotech Sainte-Bretagne, and then IDIVAL from Spain, who is also hosting this session. The picture is from our kickoff meeting 1 year ago. This is the only time we have met all live. So COVID-19 has really hit us kind of hard with this project as well. We're of course working a lot then online, but it would always be nice to meet people face to face and discuss more face to face. Okay, so objectives. We are trying to improve the implementation of policies and programs in terms of e-health, and customer orientation is in the center of our project. That is kind of the way we are looking the whole e-health concept. We are looking it from the customer orientation perspective. And then we are trying to influence the regional operation programs or regional strategies in our regions. So that is also a main one core element of Interreg Europe program. Some of our activities, we have collected 50 good practices already from the regions related to e-health, and you can find those on our website, interregeurope.eu/intensive. And we have now started evaluation process of those good practices. We are using a PICVA model to do it. It's a Danish model, and I will talk about the model more during the practical workshop if you will attend. So just shortly saying that it's a kind of a customer evaluation, or during the model there's different group interviews which are used to assess a good practice, and then hopefully maybe develop it further as well. So we are exchanging good practices between the project partners, doing study visits and workshops online currently. Let's see how it involves during the project lifetime. And then also we are doing action plans for all regions. Then during this project, we will also do a follow-up of those action plans. So kind of see if there's some action that has been written in the action plan, to see how it works out in the future, and did it get funding and so on. So that's also one of the elements here. Okay, that was all. There's our Facebook page, and we also have a LinkedIn profile, and please do visit our project pages, and you will see more what we are about there. Okay, thank you.
Thank you, Sana, for your presentation. As you have commented, the development of many projects is now more than ever a real challenge. COVID is beating all of us, so we have lost some opportunities to seeing us face to face, but the reality shows us that we can do many things in other ways. So this is something that is also applicable to telemedicine, and we're talking about tele things. Okay, so we have finished this first slot. I think that Sarah, that is connected, has some instructions for the next one.
Yes, thank you, Galo. Morning, everyone. Now it's time for the project interactive session. In the chat, you have the different links. So please select one and join in. At 5:11, we will back to this main session again. So have a nice time and select one. If you have some questions, please write to the chat, okay?
Gracias. Hi again. I think that people is still connecting, coming back from the other chats. So we have to wait to Oscar. Oscar and Carlos. Is coming.
I'm here.
So, hi again. I think we are all ready to begin the next slot in the morning. So I hope that the practical workshop will be fruitful for you. So we have now time for the round table with Marisa, Oscar, Sana. You know, we have presented than before. And now we have incorporated to this round table that we will talk to the present and future of telemedicine. We have incorporated to Carlos Parra and to Laura Herrero. I would like to introduce briefly who are they. Laura is part of IDIVAL team. She holds a degree in telecommunication engineering and works at the innovation department of IDIVAL since 2010. She works as an innovation manager, accompanying and promoting the ideas of the healthcare professionals. And she's part of the ITEMAS platform. She's born in 2010. Also, in 2014, she works as a human factors engineer in our research group, Valdecilla, where she has led several projects related with human factors engineering and patient safety. She has had the opportunity to develop several fellowships in the USA, in Washington, MedStar Washington, and in Canada, in Human Era in Toronto, that are reference centers worldwide in human factors and ergonomics. So now she's working with the IDIVAL team in the supporting the Cantabria healthcare system in the implementation of new e-health tools. So her view in relation with the road table of today, I think that is relevant. Also, we have for the discussion in the team to Carlos Parra. Carlos Parra, hi Carlos, is part of the ITEMAS team. He's a relevant person, head of the Technological Innovation Unit in a hospital in Seville, in the south of Spain, Virgen del Rocío, and also the head of the research and innovation of our research and innovation group of biomedical informatics, biomedical engineers, and health economics. He is honorary assistant of the Computer Science School at the University of Seville, and is leader in several important relevant projects in the field of telemedicine and ACT. I would like to highlight especially his role as a consortium coordinator of the FAIR4 project, that is a Horizon 2020 project. So you are very welcome. We have time to develop a brief presentation about what are your vision about the present and the future, respect your role of telemedicine. And later we will have a round of questions for the audience through a platform. And in relation with the results of these questions, we will discuss about what this means. The audience can also send questions to the speakers, getting up the hands through the Zoom platform. So thank you again, Carlos. It's your time. Later on, we'll go Laura, Marisa, Oscar, and Sana by this order. Carlos, thank you.
Good morning. Thank you very much for IDIVAL to the opportunity to participate in this interesting workshop. Very opportune workshop now in COVID-19 pandemic time. And in my background, Galo present my short bio. My background, I have important experience, I think, good and bad experience working in innovation in telemedicine. Also, I have an important experience in European Innovation Partnership on healthy and healthy hygiene, because I am one of the co-coordinators of Action Group A1 about adherence of treatment. But in any case, I know well this European initiative and strategic initiative, and also Andalusia is a reference site of paper on AHA. But today is not the matter of this discussion. My more important experience in telemedicine is about stroke. I work a lot of years with neurology department of my hospitals. Maybe this project is a set of projects, not only one. It's a program. It's a research and innovation line work a lot of years, and related to how can telemedicine can support diagnosis and prescription in the use case of stroke in acute phase. It's a very specific critical situation where apply telemedicine, and it's a very interesting experience at the end, because we in our case work all the way since the research and how can develop technology and how can implement in real healthcare, and we have lights and other problems. How can at the end implement real telemedicine in stroke? At the end, we identify opportunities and problems in all aspects about technology, about the literacy of healthcare professionals, about the organization, about how can the technology strategy in the healthcare public provider, in this case as Andalusian Health Service, adopt the new technology to scale, or at regional level the telestroke in this case. I think this will be my more relevant experience. I have others related to how can support telemedicine to diabetes patients and so on, but this will be my approach about during the discussion, during how can respond the questions, and I will try to show some examples about this experience. Okay, thank you.
Thank you, Carlos, for your presentation. What you have commented, I'm sure that later on will be a matter of discussion, and this is one of the ways to focus telemedicines. I mean, illness-specific centered telemedicine. So this is a model of piloting, and we should think about what is the best model: patient-oriented, sector-oriented, or illness-oriented. So later on, we'll talk about this. Thank you, Carlos. So Laura, this is your time. Go ahead.
Thank you.
Thank you.
Thank you, Galo, for inviting me. I have prepared a brief presentation, and I don't know if it's better to use it. Okay. Just a second. I don't know if you see it.
Not yet.
Already or not?
Not.
No. Well, if not, I can.
Try now, Laura. Okay.
Okay, perfect. Do you see it like full screen? Okay,
yes.
Perfect. Well, I have 5 minutes, so I wanted to introduce why I am here and what is my perspective. As Galo mentioned, I work in a research group called Valdecilla. We are centered in human factors engineering, and today I want to share how human factors can be a tool to implement telemedicine. So first I want to introduce how we as human, we make errors and voluntary errors, and how healthcare is one of the most dangerous industry in the world, in which 1 out of every 600 encounters end fatal. Like there are deaths that can be prevented. And I want to acknowledge that healthcare is a very complex industry in which people want to do the work the best they can, but the system, understanding system that we're going to see, force them to make mistakes. So the idea of human factors is that we don't redesign humans, we redesign the system within which humans work. And what is human factors engineering? The aim of this science is to understand how human, in this case patients or healthcare professionals, what are their limitations and capabilities to design systems, technology, and processes to meet those needs in order to improve safety, efficiency, and quality of care. One of the definitions of human factors engineering in the world of healthcare is that is a safety science. So this is what I meant before about system. This is what we understand as the term system. We know that professionals or patients are persons that work in an organization that has its own mental model. They use technology and tools in order to perform their work. They perform tasks in a specific environment. And the interaction between all those components of elements of the system has an impact. And the introduction of new technology, for example, the introduction of new people, the change in which professionals are working has an impact on the whole system, and that's what we focus. And another message I want to incorporate, because maybe later on the discussion we can profound about it, is that the difference about work as imagined and work as done. Like when people think how they do their work, and when they work or talk together, they abstract in order to develop new processes. When we train people and we simulate, when we observe, all those components are different. So the key message I want to leave here for the audience is that it's very different how we think we do our work and how we finally do it. So we focus also on that. And in Valdecilla, in my hospital, we have created a group of professionals, a multidisciplinary team, in which different profiles, engineers, biotechnologists, clinicians working as clinicians or as managers, we work together in order to have an integrated vision of the healthcare system. We work with an international ally, MedStar Health, which is the main expert applying human factors in the United States, and is an assessor for the FDA, and the Congress. And we have other collaborators, as Carlos said, the Center for Global Health Innovation in Toronto, the Mass General Hospital, Boston Children's Hospital. We have different capabilities, and here I want to share later on maybe how we incorporated this vision of human factors engineering and cognitive ergonomics into the implementation of technology of telemedicine in a very specific area, in this case of post-surgical patients that go get discharged sooner than usual, and they are monitored at home by the home care service at Valdecilla. And for example, another case that we developed is some recommendations on how to use telemedicine for healthcare professionals, given this, as Carlos mentioned before, this COVID pandemic. And that is everything I want to share for now. I want to leave some messages for the discussion later.
Thank you, Lara. I think that your vision has some similarities with other ideas like those that Sana presented. The idea is that we have to think a lot about the user when we are deploying telemedicine. So it's a critical issue, and I'm sure that later we'll have the time for discuss about it. Thank you.
Thank you.
So Marisa, do you have time for present your vision, respect your profile, your company, TiChron?
My name is Marisa. I work in Future Balloons. It's a software company that works in Portugal. We also, besides the development of software, we have the projects area. So this is what we do. I believe I'm here now because of the TiChron project. Because this was I can say that this was my first contact with telemedicine, with all the tools that we have created. So the TiChron project, it's a collaborative project whose aim is to develop and implement an action plan for responding to the specific health needs of children and young people with chronic diseases, and involving all their social environment, parents, teachers, and health professionals. So the project has developed 4 tools to help the children and the young people in the monitoring of their health. So we have developed the chat box, the e-learning platform, a mobile game that also has a web application, and the online consultation. So we are still developing. So the project started in 2018, and it will end in June 2021. So we are still working. We are at the moment, we are starting with the piloting phase. So in Spain, we are piloting the diabetes. In France, we are piloting the obesity, and in Portugal, we are piloting the asthma. My company, Future Balloons, is responsible for the development of the learning platform. So we don't have connection to the health system, let's say. I'm not sure if you want to say anything, or can go to someone else.
Okay, thank you, Marisa. I think that your view is also relevant. I mean, we need that companies that develop software understand well what is the path for developing innovation, for implementation in the healthcare system, and we need project managers that understand what are the keys for developing platforms. Probably in the next few months, with the development of the new programs of the European Commission, we'll have a lot of opportunities for funding new projects centered on health. So the relevance of the project managers is key and probably will be more important. Thank you, Marisa.
You're welcome.
Okay, Oscar, medicine man ahead.
Gallo, thank you so much. I was already introduced the beginning of today at 10 o'clock, and I had my presentation, so I will keep it short. My name is Oscar van Dijk. I'm the CEO and the founder of Medicine Man. Our company now exists for 7 years, and we developed a telemedicine platform called EMMA, And Emma has a number of what we call them interventions or applications on top of it. I was asked to tell why I'm in telemedicine, and I realized that for me it's different than from most others. I already had different ventures. I'm an entrepreneur for over 30 years now, and I see my role now in health to put my experience now into, say, new products. And I already said I think in my presentation, both my parents were doctors, and my grandfather was doctor. I didn't decide to also go that direction. I've spent most of my career in software, developing software for consumers. And when my wife got very ill about 10 years ago, and fortunately she and the family, we survived that period. But it all came together, and I realized that this was the I would call it the sector, the industry I wanted to be in. I also realized that I had this experience on how to work with, to interact with, say, people, with consumers, with patients. And this is how we all started. And I think I mentioned that in the presentation. The first 2 years of Medicine Man, we only worked together with patients, with no health provider there. We really wanted to know how patients would want to work with it, because we believe, and I think that's still the case, is that most telemedicine platforms start with dealing with the health professional and how they believe that the patient should work. And of course, you can have all these meetings with patients and see how it works. And we believe that you should always start from the patient and have them in as quickly as possible. In fact, we adopted what is called the agile and development methodology, and what is called the lean startup. If you don't know what it is, look it up. But it also means is that we develop a new function or a new prototype, whatever, as quickly as we can, and then have patients work with it, because that's the only way to find out if they really want it. I realized quite early on that the kind of applications that work best are those for the people who are chronically ill. And why is that? Because everything about e-health is you have to tell people how it works. It's relatively complicated. And if you have something that is for someone who had an injured knee, then it's only for a period of a couple of weeks that you need this intervention. Well, if you have something for chronically ill people, they have the advantage over many years. So it can be more complicated, and you can have these setup time for them. And to make that work, you have to start especially with the patient, because they really have to want to work with it over years. So that philosophy you put in there. There was something else I wanted to mention. This is a frustration of myself. I found out that, and it was in the Netherlands, and maybe it's different in other countries, is that very often there is a lot of money available to do research on, say, a new e-health intervention. In Holland, very often it's a 4-year period, because there's someone who has to get his PhD, which is often 3 to 4 years. And then most of the money is spent on the research, because that's what it's about. And about 5% of the money is then spent on developing this intervention. And then 95% of the time is used to prove that it doesn't work, because you never spent enough money on developing the intervention. And I hope that we're getting around that. And I also hope that telemedicine platforms like Emma and other platforms actually can help make that work better, because that 5% spent it then on an existing platform, and then do research on your intervention, because the platform is really like the infrastructure underneath. Don't try to reinvent the wheel. Well, I can continue for 15 minutes. I won't. Gallo, back to you.
Okay. Well, thank you, Oscar, for your excellent presentation and your excellent ideas. It's quite complicated to create tools for telemedicine, and you have got it, and you have the results. So congratulations. And it's key. Co-create. We have to talk with INTENCIVE. We have to talk with Valdecilla. We have to talk with Emma. Co-create, co-create, and co-create. So probably this is one of the key elements for success in the implementation of e-health. Okay, and now we have time for Sana. Please, Sana from Ostrobonia, go ahead.
Thank you, Gallo. Shortly, Gallo already in the beginning introduced myself, so I will just shortly talk about the organization I work for. So the Regional Council of South Ostrobothnia here in Finland. It's a kind of a development organization. And we do regional planning, regional funding, and we are not directly linked with health and social field. So in Finland, hospitals and municipalities are mainly are at the moment responsible for health and social services. So from that perspective, my background organization is a bit might be a bit different from others. We do kind of offer roundtables a lot, so for different stakeholders to come together and talk. There's also an ecosystem built here in South Ostrobothnia. The Seinäjoki University of Applied Sciences is a key actor in that one, and we have close connection with them with e-health, and we work a lot with different stakeholders, of course, and perhaps few points that maybe haven't been said already. One is infrastructure, so like mobile connections and that kind of technical background, and which kind of needs to be in order before people can start working with e-health solutions, probably with the good results. And as well, another key issue is the skills of people, the citizens, digital skills. They are still in many places, especially with the elderly people, a bit in a like behind. So I think that is also a key issue to talk about, how we can educate people with their digital skills and help them use different kinds of solutions. That's shortly from me. Thank you.
Thank you, Sana. Thank you again. So after this brief introduction, we have time to questions, trying to understand who is the people connected on the other side. We are launching now a survey. You can connect through a link that is in the chat. Leave boxvote.com with a number, with a PIN number. So, and you will see soon my screen where will be the results of this survey. Please connect to connect to I think that you are seeing my screen, to live.boxvote.com with this number. Okay. So in order to only create interest and to understand what we think that is telemedicine, and what is your experience, the experience of the audience in telemedicine. We are launching these questions, so you will have around 1 minute to answer this survey. And from this point, so we will start, 30 seconds. Okay. Have you any experience as patient with telemedicine? I have punctual experience with telemedicine as patient. I have usual experience. My experience as patient is not relevant. So later on, the participants in the roundtable will discuss about these questions. Also, if you have any other question, please get up the hand in the platform, and Sarah will give you the opportunity to give your opinion or send your question, okay? Okay, well, my experience as patient is not relevant, and around 25% of the total, and is around half of the patients that have had any experience as with illness and with contact with the healthcare system, they have experience with telemedicine, and the other half have not experience with telemedicine. So I think that is relevant because it means that we have a lot of field to improve. And this is surprising because everybody, I think, has any experience as patients, even with vaccinations, with laboral medicine or something like this. So based on this result about the experience of the patients represented in the audience with telemedicine, I would like to have the opinion of the speakers, beginning again with in the same order that we have had with the presentation. So Carlos, perhaps you can have any ideas about what do you think about the experience in general in the population, Andalusia, or even in Spain, or even in Europe, with telemedicine, what things we have got and what things are pending?
Thank you for the question. I think the last months can change the situation. I think this survey was different if we make the survey last year, for example. In my case, my short experience in telemedicine like patient is last month, where to contact with my primary care center to follow some medication, etc. This is now one important time to change the expectation of patients and professionals, and to implement and adopt real telemedicine in our healthcare environment.
Okay, thank you, Carlos. Another, this is only an idea, another question that is in this question is what the people means with telemedicine. So probably we have more experience that we think are thinking about telemedicine. Platforms, messages, even phone, or something like this. Okay. The question is that many of these telemedicine experiences are not structured and incorporated officially in the healthcare system. So we have still things pending respect to how we organize, we arrange the e-health tools, e-health capabilities. Okay, Laura, perhaps you have an idea about this?
Well, I was going to say that I agree with Carlos and also with something that Oscar mentioned before, that actually the COVID pandemic has changed a lot in what you mean, that we gain more experience with telemedicine, but not specific or real telemedicine programs in our systems. At least in our region or in Spain, what we have seen is that primary care has gone straight, like in 1 week, from all presence care to telemedicine care. And professionals have not been specifically trained. They have not been given the tools. And so we have, or at least I have seen, that instead of going to a structured telemedicine program with a specific video conferences for specific diseases or situations, like video consultation or synchronous or asynchronous consultation, we have gone, or at least here in Cantabria in primary care, we have seen how it has gone to phone calls. Even the patients have been eager to gain access to telemedicine, and they have asked. And I remember what we've lived here, that there was a news in the newspaper saying that the Cantabrian healthcare system had integrated telemedicine or video consultation in their APP, and people went patients went straight to using it with no doubt. So people are eager, but I think that maybe because of the situation, it has not been completely structured, or professionals at least feel that they have been a bit of late there. And this is maybe because what Oscar mentioned before, we have seen a lot of funding for piloting, for testing, for doing research studies, and mostly centered on chronic diseases, elderly. And that's maybe why we have not experienced that, because we're not elderly people or chronic diseases patients. And most of our healthcare professionals haven't been involved in big or large scale pilot studies.
Okay, thank you. Laura, I absolutely agree with you about that. Implementation needs time, needs efforts, needs resources, and in general, people love the idea to use telemedicine. Okay, so thank you. Oscar, any idea about this?
Oh, okay, about this.
Yeah.
Yeah. It sounds a little bit cynical, but sometimes I have the idea that health professionals are looking for tools to help them help patients. And a lot of what telemedicine should be about is not helping professionals to help patients, but having patients help themselves. But there comes a paradox, because this means that we're substituting some of the care that professionals are giving now to patients. And I know from the Dutch situation where hospitals, well, they just have to make the revenue. And once they get to this point where they realize that it actually works, and it can, like in EmmaCOPD, as I presented, it helps reduce the number of hospital days, then suddenly they get anxious, like, okay, but this means I will have empty beds. And I know this, as I said, it sounds very cynical, but we see this movement now in Holland, is that hospitals are getting a little bit worried that after all these years, it now really starts to work. Patients, on the other hand, of course, they are very enthusiastic. Just this morning, we got a message, not a message, actually it was in a newspaper, that a hospital we just started to work with for EmmaCOPD is that they got a lot of cases of corona. So the hospital now has to shut down. They have to go in quarantine.
Yeah.
And this is just an example of if these people already had something like EmmaCOPD, they would not be in hospital and they wouldn't get probably the lung attacks and well, would not be in this situation. And I just hope that it will change quickly. I think that, and this is maybe I call it the bright side of Corona, is that we all see that it really, telemedicine really is a very good addition to what we're already doing. And I'm not saying that it will replace, of course it will not replace. I've been in the client board of my local hospitals for 2 years, and the hospital started to experiment with telemedicine. And my fellow members, one of them said, well, you have to watch out. If we change the care path from what is done now, everyone goes to the hospital. Instead of this, they use telemedicine. They won't have to go to the hospital anymore. A number of people will be left out because they cannot work with. And this is something I think we should realize. It's that telemedicine can work probably for 80 or 90% of situations, but we still have to take care that the other people who cannot work yet with telemedicine, that they're not left out.
Thank you, Oscar. This is an interesting idea and quite relevant. We have to empower patients, and telemedicine is a nice tool to help him. Really, the idea is not to help professionals, to help patients. The idea is to help patients, really, to be autonomous, to have to give auto health. Okay.
In fact, it also.
Well,
go on, Laura.
No, sorry. I was going to say that I don't think there's a need to choose. Like, telemedicine is such a broad concept that it can go from a phone call to an APP so that a patient can have more control of their own illness. It can be synchronous communication. It can be exchanging documentation. So I don't think there's a need to choose what is telemedicine good for. Like, I hope there's always a good a situation or where it can be applied. But just that comment. Sorry, Oscar.
No, go on.
Okay. Yes, probably we are thinking about different uses of the same tools or different tools. Communication among clinicians inside hospital, among GP with a specialist and something like this. And this is telemedicine also. And the idea to communicate with the patients and to give more freedom to take information, decisions, and how they have the relations with the clinicians. Okay. So Marisa, an idea about this?
About telemedicine. So,
yes, the patients and the positions of the patients about the tools of telemedicines.
Yes, I believe that all the tools that are developed must have advantages for users and also for health professionals. They both must have advantages. So for users to control the disease, and for health professionals that can help the users or the people that has some disease. For me, it makes more sense to use the telemedicine with chronic conditions, because they need to be followed up. So I believe that hands-on care is irreplaceable. But the telemedicine can save time, can create efficiency, and it can be helpful for both users and health professionals, but cannot be a substitute, but a complement, I believe.
Okay, thank you, Marisa. Okay, we are talking about different things. So the view of the improving efficiency and the view of improving satisfaction, and are different things. So we have a question to the audience. Do you use telemedicine? Many of them have said that yes, but we should ask, do you want to use telemedicine? Because the position, the preference of the patients is essential. And we should consider that some patients may say not in some circumstances. And so this is something that I would like to understand better in the audience. So we have a second question. And the second question is, are you clinician involved in the use of telemedicine? So we have talked about general population, and probably some of the people at this in the audience may be clinicians. So we will give 30 seconds for this answer. I am clinician and I do not use telemedicine. I am a clinician and I use no institutional telemedicine tools, and I am a clinician, I use institutional telemedicine tools, and I am not a clinician. Okay. So 30 seconds, I think that is enough because the people is yet connected to the libboxnote.com. Okay, so most of the audience are not clinicians. So this is a...
Can you share your screen, please?
Oh, sorry. Okay. I thought that I was sharing my screen now. Okay. Are you a clinician involved in the use of telemedicine? I am a clinician and I do not use telemedicine. I am a clinician and I use institutional telemedicine tools. I am a clinician and I use institutional telemedicine. I am not a clinician. So most of the audience are not clinicians. And this is something that I think that is a bit surprising because we are thinking many times about end users, but clinicians are also quite relevant users. So, and Oscar commented before that many times some of the tools have has been developed thinking about clinicians, and some of the tools do not think even in clinicians, only think about ACT experts. So we need a view of the patients, we need a view of the experts in ICT, we need the view of the clinicians. We have more questions, and before pass to next, I would like to know, Sarah, if we have any question in the audience.
Yes, we have some of them. There are some spectators that want to make a question with microphone. I will take on her microphone, so now you can ask your question. Lariclia?
Hi, I wrote my question. I'll tell you, I work very, very hard to be able to attend these types of meetings as a clinician. And I think that I don't know how, but somehow, maybe through the professional networks rather than the working groups, which also tend not to include clinicians as much, we need to attract the clinicians, the people who are actually on the front line. Whether it's primary care physicians, emergency room physicians, specialists like cardiologists, in the COPD area, the respiratory related fields, not just the physicians, but the allied health personnel, they have to be specifically approached for this because if we do it through this particular type of network, you don't get to them. You don't get to be in touch with the real people working out in the field. You're addressing primarily an academic or a business kind of a model, but not the real people on the field. That's my gut feeling, and I find this. I'm bringing it up because even though I sent the invitation to people to attend this type of workshop, to people that I think will learn from it, they look and see the program, and afterwards come back to me and says, it wasn't, I didn't understand what they were talking about. So there's a gap, I think, that we need to figure out a creative way of bringing the solutions together. And I know this also from, we have started individual groups. We don't call them scientific or anything, but get-togethers to play with these toys and talk about them and where they might be useful. Not in any way, just so people get to touch it and see what we are talking about. The gap in knowledge of what exists and what is possible is quite large. Thank you.
Thank you, Clarissa. Well, obviously, one of the challenges for telemedicine and in general for innovation in healthcare is to involve different agents, and clinicians are key. We have talked during the presentations a lot about patients, but clinicians are also users and also responsibles of the Healthcare Act, and so it's compulsory to consider their view, their experience, in order to design the tools and to define the processes of healthcare assistance in telemedicine. So thank you, Clarissa.
I appreciate this very much. And I would, if I have 1 second, I would like to say that the empowering the patient and having him be part of the co-creation would be a lot easier if their physicians were also at the same time being trained, and then they can talk to each other afterwards. Thank you.
Thank you. Probably one of the reasons for the low audience of clinicians is the COVID situations. We works in the healthcare.
Don't hide behind the corona. This is a real issue. It will pass the corona. You'll see it.
Maybe. So, Carlos, perhaps do you have any idea about this?
Yes, I think the point of view of clinician related to the telemedicine platform tools, I haven't clinician, but I have a lot of experience with working with clinicians in telemedicine, and I think a key word is trustworthy. The platform must be trustworthy. The clinician take the decision about the health of persons. The information must be very, very confiable. And for example, I think the perspective about patient is very important, but also the clinician need use this kind of tools in clinical workflows, in real healthcare settings. For example, very, very important is the interoperability of information with electronic health records with patients. Every decision and every healthcare act need take information, and we need record this information, because at the end, if we have some consequences related to this kind of act, the responsibility for the clinicians. I think it's always we need the balance, the need of this requirement, because it's very important, a perspective of patient, etc., of course. But at the end, the decision about treatment, about diagnosis, etc., is for clinicians and need very good information, and for example, about lab tests, about some imaging results, and also related to the observation of with patients. And I think a key important aspect to the adoption of clinician of some tools is how can adopt this kind of tools in the real healthcare setting related to healthcare, electronic health records, about the privacy, confidentiality, about the security of information, and also about the safety of patients. I think my opinion about this.
Okay, thank you, Carlos. Any idea? We can pass to the next question. Okay, so Carlos, you are talking about electronic health record, and the healthcare system is so complex that we need many different tools in order to deploy all the telemedicine. So electronic health record has the classical view for the clinicians, and we have to give other steps to give the view to the patient, to follow up the processes of the continual assistance with primary care and so on. I think that many hospitals have electronic health records, and this is something that probably is not optimal, but is enough at this moment. But the experience with the attendance of the patient at home, with the continuity of the assistance with primary care, I think that this is something that in general has to improve a lot, or at this time is lacking.
Of course, but I think we know some new possibility around in the electronic health record. For example, the information of healthcare is not only the electronic health record, it's an ecosystem. And for example, the standards of clinical information develop some specification related to how can connect APP with electronic health record. For example, we know one important experience, Smart on Fire. Smart on Fire is one initiative to how can connect information of mobile phones for clinicians, for patients, etc., with electronic health records in the market. Some biggest companies of electronic health record like Epic or Cerner use this kind of connection to develop this ecosystem to connect information in the continuity of care of patient, and how can connect all the stakeholders in this environment.
Thank you, Carlos. Okay, so I will share again the screen. We will go to the next question to the audience. What is your position about telemedicine? I love the idea to use telemedicine always it is physically possible. I do not like telemedicine. I prefer presential medicine. I want to use telemedicine only in some circumstances. So 30 seconds for respond. So I have to say that respect to the position about telemedicine, so the regulation is also quite a relevant issue. And for example, in Spain, a first consultation with only telemedicine tools probably is not supported on the actual regulation. So this is only an example of how regulation can influence the use of telemedicine in Spain and other countries. Okay, so it's incredible. So everybody wants to use telemedicine. It's true that some people say only some circumstances, but more than half of the people here in the audience say if I can use telemedicine independently of in what situations, if I have a device, if I have a good connections, I love the idea to use telemedicine. So if we have the technology and if we have the desire of the patients and desire of the clinicians, why do not have success with telemedicine? What we are failing in? So this is an issue to think about. What do you think about this? Anyone to go ahead? Laura?
That we want to use it, you mean? What do we think?
Yeah.
Well, I have been using like telemedicine since, meaning telemedicine that I have to lead to small girls, and I always call their pediatrician. I hate going to the doctor because it involves going home, taking the child, driving to the primary care center, talking maybe 30 seconds, 1 minute, and going and driving back. And that means losing time of work and having to work later. It means getting the child in the car. Like, it's so frustrating that getting my phone, calling the pediatrician and saying, look, this happens. Oh, don't worry, or take her to the ER. It's so life-changing that I think there's a lot of people, like in my case, for that use of telemedicine, there's a lot of people wanting to use telemedicine, and there is a lot of healthcare professionals that want to have to use it, but they need the tools to use it. And I think that's what we are lacking here, that there are the resources. I think someone mentioned in the audience, there are no enough resources for using telemedicine. Professionals haven't got the structure, haven't got the tools. There are no common tools for all of them. So I think it's going to be bottom up. It's going to be patient and healthcare professional driven, but we are finally going to use it.
Okay. You are saying that we will finally use it. It's curious because this week, we share some experience in 1999 with the use of telemedicine in the UK. That was frustrating. So I think that the history is the same all the time with telemedicine, and we have no takeoff. So, and you have talked about the technological barriers. We need technology. We need PCs, we need cameras, we need phones, we need secure connections, we need internet. But sometimes you have. So it's complex. What I mean is not only to say, even with COVID, the people is going to the hospital for consultations. Even with COVID, everywhere in the world. So I think that is, and my reflection is telemedicine implementation is a huge challenge. A huge challenge. So if someone thinks that this is easy and is beginning to work for implementing telemedicine, he will get frustrated.
Well, if I may, I think healthcare industry is one of the most complex industries in the world, and most practices or most processes are not or cannot be standardized as in many other industries. And I think that's one of the main issues when implementing technology, because it's not as easy as, so here you have, so I mean, technology is very important, but it's not as easy as here you have a camera, here you have a microphone, and please start. And I go back to the system image that I showed. Any change or any small change in one part of the system has a lot of impact in every other. So I think there's, when implementing technology, one of the main keys to have that in mind and address most of or all of the components of the system.
Okay, and another issue that we have experienced with innovation is sometimes the implementation of the telemedicine or of innovation in general require resources, specific resources. So you have to have a plan, people, and time dedicated specifically not to the use, to the implementation. And if you don't have a plan, people, and time, sometimes the innovation do not get implementation. We have in every hospital in the world experience with new devices that never get used, not only with telemedicine. So we are thinking, we are talking about the general model of implementation of innovation. And the challenge is that e-health and telemedicine is especially complex.
True.
It's
May I
not,
say something, Galo?
yeah.
I totally agree with that. And what I've seen is that not in every hospital there is what I would call an innovation function. They do what they do, and they do it really good. But to change, in this case, care paths, you would need an innovation function, and you need an innovation manager. And if a hospital doesn't have an innovation manager, you're already in trouble. And we see in the projects we had and we're doing now, is that this is a key element, an innovation manager that is not just, well, managing the project, but also has all the connections inside the hospital to move the clinicians, to move the board, to move every nurse in the hospital if necessary, and also manage the project and take care of the budget. This also means that implementation in a hospital, if they have the innovation manager and the budget, is easier than, for instance, with GPs. GPs in Holland, but probably most countries, they have a few people in there, maybe 2 GPs, maybe some assistants, but no innovation function. And there you go again, is that for them it's very difficult to change. I would like, for instance, in the Netherlands, but probably also in other countries, that the government would see that and provide innovation managers that help GPs and maybe other organizations as well to get through that innovation problem. Because as you said, it's very difficult. There's not much information, not much knowledge and experience. So I think on a national level, this should be bundled. But this is my idea.
Thank you, Oscar, for your vision. I think that all we need a guide like Carlos, that is the innovation manager. Yes. Okay. So, and even with a nice innovation manager, things are not easy. So, I think that we have time to another question, if you want. So, in your opinion, what are the keys for success for implementation of telemedicine? This answer has to be responded with 1 to 4. 1 is the most important issue and 4 the less important. Adequate planning for implementation, improve of technology, improving users, specific resources for supporting its deployment. Planning, technology, users, or supports for deployment. One to 4. 1, the most important of the 4. 4, the less important. So, wow. So only five users voted. So we have few information. Okay, we open again the survey. Okay, 5 seconds and okay, 18 users. So it's surprising because the figures are similar. So probably it has sense because you need to consider all the issues where you are thinking about implementing technology. You have to plan it, you have to improve, you need adequate technology. Obviously, you need to train the people, the patients, to improve the culture, to define whether the capabilities of digital skills that you need, and to define specific resources for its deployment. So, do you have an idea about this? How do you develop the implementation of the telemedicine, Carlos, in your hospital most of the times?
The four aspects are very relevant for me. Difficult to select the first and the last option. I think the planification is very important, but I think the skills of the engagement of the stakeholders, patients, professionals, etc., can be in my opinion now, a very, very key aspect, because if the people try to achieve the whole, implement telemedicine to make better healthcare, a lot of barriers can lose. For example, I think also if the professional identifies some tools relevant to improve the value of his activity, can achieve a lot of agree with other professionals, with the managers in the hospital, managers at regional healthcare provider level, to adopt. I think in my case, it's important that the leadership of this kind of initiatives. If, for example, I have my point of view is very specific of professional and the healthcare provider. I work in hospital, and it's my bias in my opinion. But I think in this kind of project, the key of success is the leadership of clinicians, and how can engage the team, engage all of the people around every project, because it's not about technology. Today we have good technology. We identify the technological aspect to make good platforms, but I think a good leadership how can engage all professionals around every project is an important aspect to the success of this kind of initiatives.
Oh, so thank you, Carlos. Any other opinion? So well, it's 12:30, so we have complete the time. I think that there are many issues pending, but we have limited time. I would like to give only one opportunity for the audience. If someone wants to say something, share a reflection, make any comments, so have the opportunity. Sarah.
Okay, Marina, it's online, it's live.
Okay.
Marina, please. You have your microphone mute. Okay.
Hi everyone. So thank you to all the presenters. It was very interesting. Yes, very quickly. I work with Galo and Laura in this human factors team called Valdecilla. We are working very hard on telemedicine, and I really liked some of the points that you made today. I read something this week. I agree with you that the main barriers are not technological. Telemedicine requires the belief that the excellent care is not always provided in person. So as project managers, we work with the users, with patients, with professionals, with both sides to know what they feel about this big change. And also, Oscar, I really like the point that you made when you said, please don't reinvent the wheel, because telemedicine is happening right now. There are some tools already available and clinicians are using it. And I think that we have to come up with solutions that are easy to use, that are similar to the telemedicine tools to the telecommunication, tools that we are already using in our daily lives. And I don't know, sorry, because I had a lot of things to say, but just thank you. And well, we will keep working together on this.
So thank you, Marina. At the end, everything is about people. Obviously, healthcare is only about people, and the implementation of tools in telemedicine, and in telemedicine in general, that because telemedicine is not only about tools, it's about people, about processes, about health, is above all about people. So we need to include in the teams the users, the managers, the patients, the experts, and this is the only way to go ahead. So COVID gives an opportunity. Things have changed dramatically in the way how we can give assistance to the patients, give care. Because COVID, some things have improved a lot, other things not. We have the obligation to use this situation as an opportunity to improve the use of telemedicine and the use in general of health. So thank you so much for your time, for your vision, for your inspiration with the projects, INTENCIVE, TiChron, EmmaCOPD, Carlos with your work in ITEMAS, Laura with Valdecilla. So go ahead and see you soon.
Carlos, do you want to hear a word?
Cherikia, yeah.
Yeah. Can I suggest, since we are talking among ourselves here, can we sort of think of some innovative way to invite the players who are missing from this discussion in the future? Just create a working group that tries to get the clinicians in and the policymakers in. Just an idea. Let's because all that you have said is exactly what needs to be done, and the work that was presenting was beautiful. So we've got to get it out there.
Thank you. Thank you. We have to count with the people. We have to count to all the actors that play the game of healthcare,
yes, exactly,
to implement telemedicine. Sure.
Yes.
So thank you, Cherikia, for your vision, for your opinion. And again, all the people who is in the audience. Thank you, Lara, Marisa, Sana, Oscar, Carlos, and see you soon.
Thank
Bye.
you. Bye.
Thank you.
Thank you.
See you. Bye.
Bye-bye.
Goodbye.
Bye, thanks.